Welcome to the deep dive. Our mission here, as always, is pretty straightforward. We take these dense, complex sources, the clinical notes, the high-yield reviews, all that specialized stuff, and we boil them down into knowledge you can actually use.
That's the goal.
Today, we're diving into a really fascinating area of medicine. It's where tumors aren't just, taking up space. They're actively hijacking the body's internal communication. It's chemistry.
Exactly. We're talking about endocrine and neuroendocrine tumors. These are, you could say, the masters of chemical disruption within the body.
It's a wild area because, as you said, the symptoms often seem totally unrelated to where the tumor actually is.
Right. These things work by just pumping out massive amounts of hormones or neurotransmitters, peptides, whatever their specialty is. And it's completely unregulated. That chemical overload causes these really dramatic effects across multiple body systems. It can stump even very sharp clinicians.
Yeah, I can see that. And we've got a good stack of sources today covering some distinct, often pretty rare conditions. Stuff like adrenal tumors causing sudden crises, pancreatic tumors that mess with your skin and digestion. It's quite the range.
It is.
So our goal for you, listening in, is to pull out those key diagnostic anchors, the classic symptoms, the absolute must-do diagnostic steps, and maybe the one critical thing about management that keeps patients safe. Think of it as the aha shortcut for these high-stakes conditions.
And because these hormones act systemically, understanding them gives you a lot of leverage, diagnostically speaking. So maybe we should start with the most explosive one, the one that can cause an immediate crisis.
Okay, let's unpack this. All right, first up, pheochromocytoma, PCC. This is basically an adrenaline factory gone wild. It comes from chromaffin cells, usually in the adrenal medulla, the core of the adrenal gland.
Right. But sometimes, and this is a key point from the sources actually, they can arise outside the adrenal gland. These are called paragangliomas. They can pop up basically anywhere along the sympathetic nervous system chain. That can make finding them a bit tricky.
So PCC in the adrenal, paraganglioma outside. But the basic problem is the same.
The mechanism is identical, yeah. Uncontrolled, massive release of epinephrine and norepinephrine, adrenaline, and noradrenaline. The result is this sudden, extreme overdrive of the sympathetic nervous system. Imagine like dumping a truckload of pure adrenaline into someone's veins maybe every few hours. It's that kind of scale.
Wow. And the effects then depend on which receptors these hormones hit, because that seems to define the whole clinical picture we see in the sources.
Exactly. It boils down to two main receptor types. First, you've got alpha-1 receptors. These are mostly on the smooth muscle lining your arterioles, your small arteries.
Yeah.
When they get hit hard, they clamp down. Vasoconstriction. And that directly causes two major things: really severe hypertension, high blood pressure, and something you can actually see: intense pallor. The person looks white as a sheet because all the blood vessels in the skin is shut down.
Dramatic. And the other receptor type?
That's the beta-1 receptors, primarily on the heart muscle itself. Stimulating these cranks up the heart rate and how forcefully it beats. So patients get severe tachycardia, racing heart, and palpitations. That feeling like your heart is just hammering away in your chest can be very frightening.
So you put those together, the vasoconstriction, the racing heart.
And you get the classic diagnostic triad. Headache, intense pounding headache from the pressure, sweating, profuse sweating, and those palpitations we mentioned. If someone comes in describing sudden, intense episodes, paroxysms of those three things, especially with sky-high blood pressure, well, you absolutely have to think about PCC. It goes right to the top of the list.
And it's not just that these episodes happen randomly, right? The sources really emphasize the triggers, things that can set off one of these catecholamine floods.
That's what makes it so dangerous, yes. Beyond general stress or just changing position sometimes, there are specific clinical triggers.
Like what?
Well, simple things like bending over or strenuous exercise, even urinating if the tumor happens to be pressing on the bladder. That's a rare but classic one. But the real danger zone is during surgery or anesthesia.
Okay.
The high-yield scenario you see mentioned everywhere is this. Patient is getting anesthesia induced, or the surgeon is manipulating tissues near the tumor, and suddenly, boom, acute severe hypertension that doesn't respond well to normal drugs, intense pallor, ripping tachycardia. The drugs, the stress, the physical handling, it can all provoke a massive, potentially lethal catecholamine surge right there on the table.
Which makes the diagnostic sequence absolutely critical. You can't just jump to surgery if you suspect this, so how do we confirm it?
Biochemically, right. And why test the byproducts, the metabolites, instead of the hormones themselves? You're exactly right. The absolute rule is biochemical confirmation before you even think about imaging. We generally don't measure epinephrine and norepinephrine directly because, well, they get broken down incredibly fast. Their levels can swing wildly just based on momentary stress, maybe the stress of the blood draw itself. So you get lots of false positives and false negatives.
Right, so measuring this stable end product gives a clearer picture.
Precisely. We measure their inactive, stable metabolites, metanephrines. The best initial tests, the most sensitive ones, are either plasma-free metanephrines, a blood test, or a 24-hour urinary collection for fractionated metanephrines. If those levels are way up, significantly elevated, then you've confirmed the chemical factory is working overtime.
And only then do you go looking for the tumor itself.
Only then. Once you know the chemistry is off, then you use imaging CT or MRI to pinpoint the tumor's location. Doing imaging first is not only skipping the crucial diagnostic step, but you could theoretically even provoke the tumor during the scan. Plus, you might find an unrelated adrenal lump, an incidentaloma, and miss the real functional tumor elsewhere.
Okay, that makes sense. Now, management. The sources are screamingly clear about this being maybe the single most important life-saving point for anyone learning this. Surgery is the cure, but what's the absolute prerequisite to do it safely?
It's all about the preoperative alpha blockade. This is non-negotiable. It's the patient's life insurance policy. See, these patients are chronically vasoconstricted, clamped down from all those catecholamines acting on alpha-1 receptors. Paradoxically, despite the high blood pressure, they're often volume depleted because their vascular space is so small.
So you need to reverse that before surgery.
Exactly. You must start an alpha blocker, typically phenoxybenzamine, which is irreversible, about 7 to 14 days before the operation. This does two critical things. It blocks the alpha-1 receptors, relaxing the blood vessels and lowering the pressure, and it allows the patient's vascular system to expand back to normal. This means they need significant IV fluids, volume resuscitation to fill up that newly opened space. They need to be tanked up.
And here's where it gets, as you said, really interesting and potentially deadly if you get it wrong. The sequence of adding beta blockers. Why is it so catastrophic to block the beta receptors first?
This is the nightmare scenario. Unopposed alpha stimulation. Think about it. The body is flooded with catecholamines hitting both alpha and beta receptors. The beta-2 receptors, found on some blood vessels, actually cause a little bit of vasodilation. They offer a tiny counterbalance to the overwhelming alpha-1 vasoconstriction.
Okay, like a small safety valve.
Sort of, yeah. Now, imagine a clinician sees the patient's heart racing like crazy, the beta-1 effect, and thinks, okay, let's slow that down. So they give a beta blocker first. What happens?
It blocks all the beta effects, including the beta-2 vasodilation.
Exactly. You slam the door shut on that tiny bit of protective vasodilation. Now, all those circulating catecholamines have only the alpha-1 receptors to act on. There's nothing opposing them. The result, catastrophic complete vasoconstriction. Blood pressure goes through the roof, often resistant to any treatment. It can cause immediate heart failure, stroke, death.
So you remove the body's last little bit of give.
You do, which is why the rule is ironclad. Alpha blockade first, then beta blockade. You absolutely must control the blood pressure and volume status by blocking alpha receptors for a week or two. Only then, if the heart rate is still too high, can you cautiously add a beta blocker. Get that sequence wrong, and you can kill the patient. It's drilled into every endocrine surgeon and anesthesiologist for a reason.
That detail, that specific order, alpha then beta, that really highlights how understanding the receptor physiology translates directly into preventing a disaster. It's not just academic.
Not at all. It's life and death. Okay, so we've handled the immediate adrenal crisis. Let's shift gears now and move to the pancreas. Here, we see tumors secreting a different set of hormones, things like insulin, glucagon, peptides. And these tend to cause problems that are maybe slower, more insidious, affecting metabolism, digestion, even the skin.
Yeah, it's amazing the variety. One tumor gives you a hypertensive crisis, another gives you like a weird rash or uncontrollable diarrhea. So where should we start with the pancreas? Maybe the one focused on blood sugar. Insulinoma. Hashtag A. Insulinoma, the hypoglycemia enigma.
Good place to start. An insulinoma is a tumor of the pancreatic beta cells, the cells that normally make insulin. But the tumor does it completely inappropriately. It just keeps pumping out insulin regardless of whether the body needs it, regardless of blood sugar levels.
And insulin's job is to lower blood sugar by driving glucose into cells.
Right. So the result is fasting hypoglycemia, low blood sugar, especially when the person hasn't eaten for a while. This typically shows up as neuroglycopenic symptoms. The brain isn't getting enough fuel. So confusion, dizziness, tremor, sweating, sometimes even seizures or coma if it's severe.
But just finding low blood sugar isn't enough for the diagnosis, is it? There's a specific pattern, a diagnostic anchor they call Whipple's triad.
Absolutely, that's the gold standard. Whipple's triad requires proving three things are happening simultaneously. One, the patient has symptoms consistent with hypoglycemia. Two, you actually measure and document a low plasma glucose level, usually defined as less than 55 milligdl. And three, giving the patient glucose like juice or IV dextrose makes the symptoms go away promptly and completely.
And confirming that often means putting the patient through, well,
Yeah.
a pretty tough test,
It
right?
can be. Often requires a supervised fast, sometimes for 48 or even 72 hours in the hospital. You're basically trying to provoke the tumor into releasing insulin inappropriately when the blood sugar naturally drops during fasting. You monitor glucose and symptoms closely the whole time.
Now, the sources really stress differentiating this tumor from someone, say, secretly injecting insulin or taking sulfonylurea pills, which also cause low sugar. How do the lab tests sort that out?
This is where C-peptide and proinsulin come in. They're the biochemical detectives. See, when your pancreas makes insulin naturally, it starts as a bigger molecule called proinsulin. This gets clipped into two pieces, active insulin and an inactive fragment called C-peptide. For every molecule of insulin your body makes, it also makes one molecule of C-peptide.
Okay, so they're produced together.
Exactly. So if an insulinoma is churning out insulin, it's doing it the natural way. During a hypoglycemic episode caused by the tumor, you'll find inappropriately high levels of insulin and high levels of C-peptide, and often high levels of proinsulin too. All three are elevated when they should be suppressed by the low blood sugar.
But if someone is injecting insulin they got from a pharmacy,
Pharmaceutical insulin is just pure insulin. It doesn't contain C-peptide. So if someone is injecting exogenous insulin, their insulin level will be high. But because their own pancreas is shut down by the resulting low blood sugar, their C-peptide and proinsulin levels will be very low, almost undetectable.
so high insulin, low C-peptide means external source. High insulin, high C-peptide means internal source, likely the tumor.
Precisely. That biochemical fingerprint is the key differentiator. Absolutely crucial for figuring out if it's a tumor or surreptitious drug use. Hashtag tagged, hashtag tab B, glucagonoma, the dermatological clue.
Okay, let's flip the script completely. From too much insulin causing low sugar to a glucagonoma. This is a rare tumor of the alpha cells in the pancreas, and it pumps out too much glucagon.
Right. And glucagon does the opposite of insulin. It tells the liver to release glucose into the blood. It's catabolic. It breaks things down. So patients with a glucagonoma often have, maybe surprisingly, mild hyperglycemia. They might develop new onset diabetes, but it's usually pretty easy to manage.
So the metabolic effect isn't necessarily the most striking thing?
Often not, no. The thing that really screams glucagonoma is this very bizarre, very specific skin finding. Necrolytic migratory erythema, or NME. It's really part of a whole syndrome, but the rash is the big clue.
Necrolytic migratory erythema. Sounds nasty. What does it actually look like?
It is pretty distinctive. It usually starts as red patches, maybe slightly raised, that's the erythema. Then these areas often develop blisters or little pustules. These break open, crust over, and then they tend to heal from the center outwards, leaving this kind of ring-like or migrating pattern.
Migratory, so it moves around.
Yeah, it tends to appear in crops, often in areas prone to friction, the groin, perineum, buttocks, lower abdomen, sometimes around the mouth or on the limbs. The necrolytic part refers to the top layer of the skin dying off, which is thought to be related to the severe catabolic state the excess glucagon causes, possibly linked to amino acid deficiencies. It's often painful or itchy.
Wow. So you have this unique rash, plus the mild diabetes. What else goes along with it?
Because glucagon is catabolic, you see other signs of breakdown, significant weight loss, often anemia, sometimes sore tongue, glossitis, and chronic diarrhea is common too.
So the diagnostic anchor is really that constellation, the NME rash, the weight loss, the mild diabetes, and then confirming it with blood tests.
Exactly. You look for a markedly elevated serum glucagon level. Typically the sources say greater than 500 picograms per milliliter. When you see that number combined with the clinical picture, especially that NME, the diagnosis becomes pretty clear. Recognizing the rash is often the aha moment. Hashtag, Z-vipoma, the pancreatic cholera.
Okay, next on the pancreatic list is the V-foma. This one secretes vasoactive intestinal peptide, or VIP, and it causes something the sources call the WDHA syndrome.
That's right. WDHA stands for watery diarrhea, hypokalemia, low potassium, and achlorhydria, low stomach acid. And the nickname it sometimes gets is pancreatic cholera.
Pancreatic cholera. That sounds serious.
It is incredibly serious. VIP is a potent stimulator of intestinal secretion. When it binds to receptors on the cells lining the gut, it triggers a massive, uncontrolled outpouring of electrolytes, especially chloride and water, into the intestinal lumen. At the same time, it makes the kidneys dump potassium.
So we're talking about diarrhea on a scale that's hard to even imagine.
We really are. Patients with VPOMA can lose enormous volumes of fluid. The sources mention figures like 6 to 10 liters of diarrhea per day, sometimes even more.
10 liters. That's life-threatening just from dehydration.
Absolutely. And the diarrhea has specific characteristics. It's typically described as watery, often tea-colored, usually odorless, and it's secretory. That means the gut itself is actively pumping out fluid. You can prove this by measuring the stool osmotic gap, which will be very low in secretory diarrhea.
And the potassium loss.
The hypokalemia can be profound, leads to muscle weakness, cramps, fatigue, and potentially fatal cardiac arrhythmias. The achlorhydria, the low stomach acid, is also part of the syndrome, but usually less immediately dangerous than the fluid and potassium loss.
So management has to be immediate and aggressive supportive care.
Paramount. First thing is massive IV fluid resuscitation and careful potassium replacement. You have to keep up with those huge losses to prevent circulatory collapse and cardiac events. Then, for symptom control, we use a medication called octreotide.
Octreotide, that's a somatostatin analog.
Yeah, exactly. Somatostatin naturally inhibits the release of many gut hormones, including VIP. So octreotide can dramatically reduce the diarrhea, often providing rapid, though temporary, relief. It buys time to stabilize the patient before the definitive treatment, which, like most of these tumors, is surgical resection. #D carcinoid syndrome and niacin connection.
Okay, one more related condition here. Though the tumor often starts outside the pancreas, usually the small intestine, carcinoid syndrome. This happens when a neuroendocrine tumor, a carcinoid tumor, starts secreting bioactive stuff, mainly serotonin.
Right. And the key thing about the syndrome, the flushing, the diarrhea, sometimes wheezing, the potential heart valve issues, is that it typically only appears after the tumor has metastasized, spread, usually to the liver.
Why is the liver involvement so critical for the symptoms?
Because normally serotonin released into the portal vein from a gut tumor gets inactivated almost completely by the liver on its first pass-through. The liver enzymes break it down. But once you have liver metastases, the tumor cells in the liver dump serotonin directly into the systemic circulation, bypassing that first-pass metabolism. Now the whole body sees high levels of serotonin.
Okay, that makes sense. But there's this really interesting biochemical domino effect described in the sources, linking this serotonin excess to a specific vitamin deficiency.
Ah, yes, the niacin connection. This is fascinating. Serotonin is synthesized from an essential amino acid called tryptophan. Our bodies also use tryptophan for another crucial job, making niacin, which is vitamin B3.
So you have two pathways competing for the same starting material, tryptophan.
Exactly. And in carcinoid syndrome, the tumor is acting like a metabolic black hole for tryptophan. It's constantly demanding more and more tryptophan to synthesize massive quantities of serotonin.
So it essentially steals all the tryptophan, leaving none for niacin production.
That's a perfect way to put it. The body prioritizes serotonin synthesis, diverting almost all available tryptophan down that pathway. The result is an acquired secondary niacin deficiency, and niacin deficiency causes a classic clinical syndrome called pellagra.
Pellagra. Famous for the 3Ds. We should definitely spell those out.
Absolutely. The 3Ds of pellagra are 1. Dermatitis. This is typically a rough, pigmented rash on sun-exposed areas. It can look like thick, dark gloves or boots, or a necklace pattern known as Casal's necklace, very photosensitive.
Okay, dermatitis.
2. Diarrhea, often chronic, watery, sometimes explosive. This compounds the diarrhea the patient might already have from the direct effects of serotonin on the gut.
And the third D.
Dementia. This covers a range of neurological and psychiatric symptoms: confusion, memory loss, apathy, depression, irritability, potentially progressing to frank psychosis. Seeing those 3Ds together, the characteristic rash, the chronic diarrhea, and the cognitive changes in a patient who also has flushing, that's a huge clue for advanced carcinoid syndrome with secondary pellagra.
And confirming the serotonin overproduction itself involves measuring its breakdown product in the urine, right?
Yes, the standard test is measuring 5-hydroxyindoleacetic acid, 5-HIA, the main metabolite of serotonin, usually in a 24-hour urine collection. Elevated 5-HIAA confirms the body is making way too much serotonin. It's quite remarkable, isn't it, how this biochemical hijacking leads from a tumor to flushing, diarrhea, heart problems, and even a specific vitamin deficiency syndrome.
So what does this all mean? We've talked about these distinct tumors, pheochromocytoma in the adrenal, insulinoma, glucagonoma, vipoma in the pancreas, carcinoid. But things get even more complex, don't they, when these seemingly separate tumors start showing up together in the same person or in the same family?
Exactly. The body isn't usually that random. When you see a pattern, especially multiple endocrine tumors, you absolutely have to start thinking about an underlying inherited genetic syndrome.
These are the multiple endocrine neoplasia, or MN syndromes, and others like von Hippel and Dow.
Right. And understanding these is critical, not just for diagnosing the patient in front of you, but because they have major implications for screening family members. These syndromes involve mutations in specific genes that basically predispose people to developing tumors in multiple different endocrine glands over their lifetime. #A, MN1, the three Ps.
Let's start with MEN1. This is autosomal dominant, linked to mutations in the MEN1 gene, which is a tumor suppressor. And it's classically remembered by the 3PS.
That's the mnemonic, yeah. The three Ps stand for parathyroid, pituitary, and pancreatic GI endocrine tumors.
And the sources emphasize that one of these Ps is almost always present and usually shows up first.
That's the parathyroid P. Primary hyperparathyroidism, PHPT, happens in well over 90% of people with MEN1, often starting at a relatively young age, like in their 20s or 30s. The parathyroid glands become overactive, producing too much parathyroid hormone.
Which drives up calcium levels.
Exactly, hypercalcemia. And that causes those classic symptoms sometimes summarized as stones, bones, abdominal moans, and psychic overtones.
Catchy, so kidney stones.
Kidney stones are common, yeah. Bone pain or fractures due to calcium being pulled from the bones, abdominal issues like constipation, nausea, sometimes pancreatitis, and the psychic overtones can range from fatigue and depression to confusion. It's often the persistent, maybe mild hypercalcemia picked up on routine labs that's the first clue.
Okay, so parathyroid is number one. What about the other piece, pituitary and pancreas?
Pituitary tumors occur frequently too, often prolactinomas, like we'll discuss later, but also others. And the pancreatic P covers a range of neuroendocrine tumors of the pancreas and duodenum, including the insulinomas, glucagonomas, and vipomas we just talked about, but very commonly, gastrinomas.
Gastrinomas, those cause Zollinger-Ellison syndrome, right? Extreme stomach acid.
Precisely. A gastrinoma pumps out massive amounts of gastrin, which tells the stomach to produce huge quantities of acid. This leads to severe, often multiple peptic ulcers that are notoriously difficult to treat with standard medications. They can occur in unusual places, like the jejunum. Finding Zollinger-Ellison syndrome, especially in a younger person, should immediately make you think about MEN1.
So putting it all together, if you have a younger patient, maybe 30s, presenting with, say, kidney stones from hypercalcemia, bad constipation, hypercalcemia again, and really stubborn heartburn or ulcers, maybe a gastrinoma. Especially if they mention family members with similar issues.
Yeah.
MN1 has to be high on your differential.
Absolutely. That combination of symptoms from different P locations is the classic alert for MNN1. You'd proceed to check calcium, PTH, gastrin levels, and likely genetic testing for the MNN1 mutation. #tag B, medullary thyroid cancer, MTC, and MEN2.
Okay, shifting gears to another genetic category, MN2. This one is also autosomal dominant, but it's caused by mutations in a different gene, the RET proto-oncogene, and it's split into MN2A and MN2B subtypes.
That's right. And let's pause on that term, RET proto-oncogene. It's different from MNN1, which is a tumor suppressor.
Oh, so?
A tumor suppressor gene normally puts the brakes on cell growth. You typically need to lose both copies of the gene, one from each parent, for cancer to develop. That's Knudson's two-hit hypothesis. But a proto-oncogene is different. It normally promotes growth in a controlled way. When it gets mutated into an oncogene in MEN2, it's a gain-of-function mutation. The accelerator pedal gets stuck down. Just one mutated copy is enough to drive uncontrolled cell growth and tumor formation.
Got it. Gain-of-function in RET. And the hallmark cancer associated with MEN2 is?
Medullary thyroid cancer, MTC. This is a cancer of the C cells, or parafollicular cells, of the thyroid gland, which normally produce calcitonin. MTC develops in virtually 100% of people with MEN2, often at a very young age, especially in MEN2B. Calcitonin levels are usually very high and serve as a tumor marker.
Now, here's where we connect back to section 1. MTC is almost always present in MEN2, but what else is commonly found in these syndromes, particularly MEN2A and MNN2B?
Pheochromocytoma. Remember our crisis-causing adrenal tumor. It occurs in about 50% of people with MNN2A and MN2B. MNN2A also includes primary hyperparathyroidism, like MN1 confusingly,
Right.
while MNN2B has distinctive features like mucosal neuromas, bumps on the lips and tongue, and a characteristic body shape, marfanoid habitus.
So MTC and pheochromocytoma often travel together in MEN2, which leads us back to that critical pre-op rule.
The absolute ironclad cannot be stressed enough rule. Any patient diagnosed with medullary thyroid cancer must be screened for pheochromocytoma before they undergo thyroid surgery.
Why? What's the risk?
The risk is exactly what we discussed earlier. If the patient has an undiagnosed pheochromocytoma hiding alongside their MTC, the stress of anesthesia and the thyroid surgery itself, neck manipulation, etc., can trigger a massive, potentially fatal hypertensive crisis on the operating table from catecholamine release.
So before you touch the thyroid in someone with MTC, you check.
You check plasma-free metanephrines or urinary fractionated metanephrines. You must rule out a concurrent pheochromocytoma. If a pheo is found, it needs to be surgically removed first, after proper alpha blockade, before the thyroidectomy for the MTC. Screening for pheo in all MTC patients is mandatory, full stop. ####C for von Hippel-Lindau disease, VHL.
Okay, one more genetic link to make. Von Hippel-Lindau disease, or VHL. Also autosomal dominant, but this one involves mutations in the VHL gene, another tumor suppressor. What's the theme with VHL tumors?
The VHL gene plays a key role in how cells respond to oxygen levels. When it's mutated, cells behave as if they're starved of oxygen, even when they're not. This leads them to produce excessive amounts of growth factors that stimulate blood vessel formation angiogenesis. So the hallmark lesion in VHL are highly vascular tumors.
Like what kind of tumors?
The classic ones are hemangioblastomas. These are benign but problematic vascular tumors that occur mainly in the retina, leading to vision loss, and the central nervous system, cerebellum, spinal cord. Patients are also at very high risk for clear cell renal cell carcinoma, which is often bilateral or multifocal, and they can get pancreatic cysts and neuroendocrine tumors too.
Okay, so vascular tumors, kidney cancer. Where's the endocrine connection, particularly related to what we've already discussed?
The connection is, once again, pheochromocytoma. People with VHL disease have a significantly increased risk of developing pheochromocytomas, often bilateral. So hypertension in a patient known to have VHL, or in a patient presenting with, say, a retinal hemangioblastoma or early onset kidney cancer.
Should trigger a workup for pheochromocytoma.
Exactly. You see someone, especially a younger person, with those characteristic VHL lesions, the brain or eye tumors, the kidney cancer, and they also have high blood pressure. You have to screen them for pheo using metanephrine testing. It's another one of those situations where finding one specific type of tumor should automatically make you look for its known genetic associates, particularly the ones like pheo that carry immediate risks if missed. All right, we've journeyed from the adrenal gland through the pancreas, touched on the genetic links. Now let's move up into the head, specifically the pituitary gland and the area right above it, the suprasellar region. Tumors here are in a really critical location.
Yeah, crammed in at the base of the brain. Even small growths can cause big problems, right? Either by messing with hormones or just by pressing on nearby structures.
Absolutely. The pituitary is the master gland, controlling so many other endocrine axes, thyroid, adrenal, gonads, growth, and it sits right underneath the optic chiasm, where the optic nerves cross. So tumors here can wreak havoc on both hormones and vision. ####A, prolactinoma, the pituitary disruption.
Let's start with the most common type of pituitary tumor, the prolactinoma. These are adenomas, benign tumors that just make too much prolactin.
Yeah.
And they get classified by size, right?
Correct. Microadenomas are less than 10 millimeters, and macroadenomas are 10 millimeters or larger. The core problem, regardless of size, is the excess prolactin itself. What does it do? It primarily suppresses the release of GnRH from the hypothalamus.
GnRH, gonadotropin-releasing hormone. That's the signal that tells the pituitary to make LH and FSH, the hormones that drive the ovaries and testes.
Exactly. So too much prolactin, less GnRH, less LH, and FSH hypogonadism. The gonads basically get shut down.
And how does that manifest differently in men and women? The sources suggest it's quite distinct.
It is. In women, the symptoms are often quite noticeable early on. The classic ones are galactorrhea producing breast milk when not pregnant, or nursing amenorrhea, which is the loss of menstrual periods, and consequently, infertility. Women tend to seek help sooner because period stopping is usually a clear signal something's wrong.
But men present differently. Later.
Generally, yes. Men seem to tolerate higher prolactin levels before symptoms become obvious, or maybe the symptoms are just less specific. They typically present with signs of hypogonadism. Low libido, erectile dysfunction, sometimes decreased muscle mass or energy. Because these symptoms can be subtle or attributed to other things, men often present later, by which time the tumor might have grown into a macroadenoma and started causing mass effects.
Mass effects, like pressing on the optic chiasm.
Exactly. As a macroadenoma grows upwards out of the pituitary fossa, it bumps into the optic chiasm sitting right above it. The optic chiasm is where the nerve fibers carrying information from the nasal half of each retina cross over.
So if you press there,
You damage those crossing fibers. This classically causes a loss of vision in the outer temporal visual fields of both eyes. It's called bitemporal hemianopsia. Patients might describe it as tunnel vision or bumping into things on either side. So a man presenting with vision problems and maybe some vague sexual dysfunction, you have to think pituitary macroadenoma.
diagnosis seems straightforward enough, measures serum prolactin. Levels over 200 ng/ml are pretty much diagnostic, right? Then an MRI to see the tumor.
Generally, yes. Very high levels are almost always a prolactinoma. Intermediate levels might need more investigation to rule out other causes of hyperlactin, like certain drugs or stalk compression from a non-prolactin secreting tumor. But the really interesting part, the management nugget here, is that surgery is not usually the first step.
Right, that's counterintuitive for a tumor.
It is. For symptomatic prolactinomas, even most macroadenomas, the first-line treatment is medical, using dopamine agonist drugs like cabergoline or bromocriptine. Dopamine is the brain's natural inhibitor of prolactin release. These drugs mimic dopamine and are incredibly effective.
How effective?
They usually normalize prolactin levels, which restores gonadal function periods return, libido improves. They often stop galactorrhea. And remarkably, they frequently shrink the tumor itself, sometimes quite dramatically, relieving any mass effect on the optic chiasm. Cabergoline is often preferred now due to better efficacy and fewer side effects.
So surgery is only for specific situations.
Pretty much reserved for cases where the patient can't tolerate the medication, the drugs fail to control prolactin or shrink the tumor adequately, or if there's an acute visual emergency from tumor hemorrhage or expansion, pituitary apoplexy. But for most, medication is the way to go. It's a real success story of medical management for a brain tumor. Tag B, craniopharyngioma, the pediatric puzzle. Okay, last stop. Let's move just slightly above the pituitary gland into the suprasellar space. Here we find a different kind of tumor, the craniopharyngioma. This one arises from remnants of Rathke's pouch, the embryonic structure that forms the anterior pituitary. And it's most commonly diagnosed in children, though there's a second peak in adults.
And being in that suprasellar location, it's all about compression again, isn't it? What structures does it typically press on?
It's right in that critical junction. It can compress the optic chiasm from above or behind, causing visual field deficits, again, often bitemporal hemianopsia.
How does that show up in a young child who can't really describe their vision?
That's the challenge. They don't say, I'm losing my peripheral vision. Instead, parents might notice the child seems increasingly clumsy. They keep bumping into furniture, door frames, things off to the side because they simply don't see them. That unexplained clumsiness can be a subtle clue to bitemporal hemianopsia in a child.
What else does it compress? The pituitary itself or the stalk connecting it to the hypothalamus?
Yes, compression of the pituitary stalk is very common. This interrupts the flow of releasing and inhibiting hormones from the hypothalamus down to the pituitary. The result is often multiple pituitary hormone deficiencies.
Such as?
Growth hormone, GH deficiency, is very common, leading to growth failure. The child stops growing or falls off their growth curve. Gonadotropin, LHFSH deficiency, leads to delayed puberty. TSH deficiency causes secondary hypothyroidism, fatigue, cold intolerance, constipation. And importantly, deficiency of antidiuretic hormone, ADH, which is made in the hypothalamus but released from the posterior pituitary, causes central diabetes insipidus.
Diabetes insipidus. That's the excessive thirst and urination one,
Yeah.
right? Not related to blood sugar.
Correct. Lack of ADH means the kidneys can't concentrate urine, so the child produces huge volumes of dilute urine, polyuria, and has intense thirst, polydipsia. They might start drinking constantly, even waking up at night to drink, or start wetting the bed again.
So you get this really specific constellation in a child. They stop growing, puberty is delayed, they seem clumsy, maybe hypothyroid symptoms, and they're drinking and peeing constantly. That's a strong signal for craniopharyngioma.
It is a very suggestive picture. And the final piece of the puzzle often comes from imaging. While MRI is good for defining the anatomy, the CT scan is often particularly helpful here because craniopharyngiomas very characteristically have calcifications within them, often along with cystic components. That calcified cystic suprasellar mass is almost pathognomonic.
And treatment. given its location and tendency to involve vital structures.
Treatment is primarily surgical resection. The goal is to remove as much tumor as possible to relieve the mass effect, especially on the optic pathways. However, these tumors are often adherent to the hypothalamus, pituitary stalk, and blood vessels, making complete resection difficult and risky.
And surgery itself often leads to.
Unfortunately, surgery, even if successful in removing the tumor, frequently results in permanent damage to the remaining pituitary function or the hypothalamus. So most patients require lifelong hormone replacement therapy afterwards: growth hormone, thyroid hormone, cortisol, sex steroids, and often ADH for diabetes insipidus. It's a complex long-term management challenge. #outro.
Wow. We have covered a lot of ground today, from adrenal crises to pancreatic cholera, genetic syndromes, pituitary problems. It really underscores how these chemical messengers, when things go wrong, can cause chaos throughout the entire body.
It really does. And maybe just to quickly synthesize those key takeaways for everyone listening, the absolute high yield points.
Yeah, let's nail those down.
Okay. 1. Pheochromocytoma. Think headache, sweating, palpitations. And the unbreakable rule: alpha blockade first before beta blockade or surgery. Get that wrong. And it's disastrous, unopposed alpha.
Got it. 2.
Insulinoma. The diagnostic key is Whipple's triad, confirmed by finding high insulin and high C-peptide during hypoglycemia. That separates it from external insulin use.
Right. 3.
Glucogonoma, remember the rash? Necrolytic migratory erythema, NME. If you see that weird migrating blistering rash plus weight loss and mild diabetes, think glucagonoma.
Okay. 4.
Carcinoid syndrome. Chronic flushing and diarrhea, especially after liver mets. And remember the tryptophan steal leading to niacin deficiency watch for the 3Ds of pellagra: dermatitis, diarrhea, dementia.
And finally, 5.
The genetic link, especially MEN2. If you diagnose medullary thyroid cancer, you must screen for pheochromocytoma before any surgery. Mandatory pre-op check.
Those are definitely the critical anchors.
Yeah.
It feels like the unifying theme here is that these conditions don't present like typical lump or bump cancers. The presentation is the systemic effect of the hormone.
That's exactly it. You're not looking for local symptoms initially. You're looking for the downstream consequences of the chemical being released. The resistant hypertension, the bizarre rash, the unrelenting diarrhea, the weird metabolic state. The answer often lies in finding the hormone driving it.
Which brings us to our final thought for you, the listener, to mull over.
Yeah, consider this. Most common illnesses show symptoms pretty close to the organ affected. Pneumonia, lungs hurt. Appendicitis, belly hurts. But with these neuroendocrine tumors, you often have a tiny hidden tumor, maybe in the pancreas or adrenal, causing symptoms everywhere else: a headache, a skin rash miles away, diarrhea, anxiety, high blood pressure. This whole deep dive demonstrates that when you're faced with really complex, resistant, or frankly bizarre sets of symptoms, you have to step back. You have to ask, could there be an abnormal chemical messenger orchestrating this chaos? Look beyond the obvious organ systems. It's often the body's underlying chemistry, revealed by these hormone assays, that provides the diagnostic aha moment. The hormone, not just the tumor location, is frequently the key to unlocking the entire puzzle.